This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. Good afternoon. My name is Doug Lair. I am a registered respiratory therapist, managing editor of the AARC Times, Associate Executive Director for the Meetings and Conventions Department at the AARC, as well as a fellow to the American Association for Respiratory Care. I welcome you to today's presentation, Airway Clearance in the Neurorespiratory Patient.
This AARC webcast is sponsored in part by an unrestricted educational grant from Guion. Guion has been honored to receive the AARC Zenith Award for the 25th consecutive year and is a critical care provider in airway and management products from brands you trust such as Puritan Bennett, Shiley, Mallinckrodt, and Newport.
Thank you, Reagan. Upon completion of this AARC webcast, participants will be able to, number one, describe the normal anatomy and physiology of a cough, describe the mechanisms of impaired cough and NMD, list 4 questions that respiratory care practitioners should ask before recommending any specific airway clearance therapy, and finally, list 5 steps for developing hospital guidelines for airway management of neuromuscular disease when medical evidence and consensus is lacking. I am pleased to welcome Ms. Lee Guion. Ms. Guion is a registered respiratory therapist and fellow of the AARC. She is the neurorespiratory clinical specialist at Forbes Norris MDA and ALS Research and Treatment Center in San Francisco. Ms. Guion is the author of both research and textbooks on ALS. She is also an active member of the AARC and the AARC's Neurorespiratory Roundtable. Now, it's important that I disclose that I am a paid employee of the American Association for Respiratory Care. Lee, in turn, discloses research relationships with the ALS Association and Philips Respironics. Brand names of products may be used only as examples of available technology. No endorsement of any one product or device is intended. Lee, hello and welcome to the program.
Thank you so much, Doug. And thank you, Shauna, for asking me to discuss this elusive and controversial topic. All right, I'm going to start by giving you an overview of airway clearance in neuromuscular diseases. As many of you know, neuromuscular diseases are not mentioned or covered adequately in any depth in our textbooks. The autoimmune diseases, myasthenia gravis, Guillain-Barré, are briefly discussed and sometimes post-polio syndrome. However, today, you may be more likely to see patients with respiratory exacerbations or respiratory insufficiency for the following diseases. Motor neuron diseases include amyotrophic lateral sclerosis, or ALS, and especially since the Ice Bucket Challenge of last year, many more people are aware of ALS, and thanks to the Ice Bucket Challenge, over $100 million was pledged towards research and treatment for this disease. Motor neuron diseases also encompass progressive muscular atrophy, primary lateral sclerosis, and progressive bulbar palsy. These may remain distinct diagnoses, or they may progress over time to become ALS. There's also spinal muscular atrophy and the adult forms, types 2 and 3, you may also see in the hospital environment. The muscular dystrophies, Duchenne's and Becker's, also involve weakened diaphragm and respiratory muscles, so you may see these folks come into the emergency or department or med-surg or the critical care units. And then the other muscular dystrophies that may involve some diaphragm and respiratory weakness include limb-girdle muscular dystrophy, FSH, and myotonic muscular dystrophy. ALS, amyotrophic lateral sclerosis, is also called Lou Gehrig's disease, named after the New York Yankee first baseman who gave his name to this disease in the late 1920s. Definitions of amyotrophic lateral sclerosis and neuromuscular diseases are loss of the motor neurons in the spinal cord, the brainstem, and the motor cortex. And the manifestations are weakening of the voluntary muscles, atrophy, flaccidity, also rigidity, and vesiculations, which are skeletal muscle twitching due to spontaneous depolarization of the lower motor neurons, muscle cramping, increased muscle tone, spasticity, and clonus, which is the involuntary rapid muscle contractions and relaxations. Familial forms of ALS comprise about 10% of all cases, and we've been able to identify 4 different genes responsible for the familial forms. The largest one at this point is SOD1. We've been able to design mice models for 2 out of the 4 familial forms that we've been able to identify. But still, the sporadic form accounts for the vast majority of cases, so we don't really know what causes it. There are about 25 genes of interest that may predispose one to ALS, but there has to be a trigger, either exogenous or endogenous, in order for it to manifest. Sites of onsets are predominantly limb or skeletal, the upper and lower extremities, which means the first weakness you may experience will be in your hands or arms or feet or legs. In about 20% of cases, the muscles of speech and swallowing will be affected. In fewer cases, the diaphragm is the initial muscle that for which you'll experience symptoms, and some patients do experience frontotemporal dementia as their first symptom of ALS. The muscle weakness and breathing in ALS is caused by the denervation of the diaphragm as the primary muscle of breathing. This occurs because the lower motor neurons, which exit the spinal cord and become the nerve roots and nerves that supply the respiratory muscles, lose the communication between the brain and the muscles that they're trying to innervate. There's loss of elastic recoil when the diaphragm and intercostal muscles are impaired, and this leads to increased residual volume and can lead to chronic compensated hypercapnia in a subset of patients. The majority of people with ALS do die of respiratory failure or complications of chronic respiratory insufficiency, and it's why, as respiratory care practitioners, our knowledge about and best treatment of these patients is so essential. So what I want to do first, before going into the pathophysiology of neuromuscular diseases, is just do a very quick review about how the normal lung functions. And you can, to visualize this yourselves, if you want, you could even put your hands over your lower abdomen or over your rib cage and just experience a normal inhalation. There's diaphragm contraction and downward movement, and external intercostal muscles expand the rib cage, so there's sort of a cantilever effect. An exhalation, the abdominal muscles move the lower rib cage down, and the internal intercostal muscles contract the rib cage. And an effective cough is is due to the contraction of the abdominal muscles, which push the diaphragm upward forcefully, and the transmural pressure, which is the pressure on the outside of the airway walls, narrows the airway and leads to a successful and large flow of air out of the lungs. A normal cough sequence involves the isometric contraction of all of the respiratory muscles, the closure of the vocal folds, the increased buildup of intrathoracic pressure, the opening of the glottis, and a high expulsion velocity of gas. Normal airway mucus secretions, as we know, provide protection and hydration of the lower airway, but they also provide a barrier that inhibits bacterial growth and the biofilm formation. They contain helpful antibacterial and anti-inflammatory properties, and mucin is quickly released in response to temporary inhaled irritants so they can encapsulate and remove them, and the clearance is accomplished through the mucociliary action. In neuromuscular disease, this normal cough response is impaired because the diaphragm is weakened, either one leaf or both. The abdominal core muscles may become weaker, and there may be bulbar muscle weakness, which means that there is weakness in the muscles of speech and swallowing. In laryngeal dysfunction, there's either a weakness or spasticity of the vocal folds, one or both, so that we don't get the important glottic closure that allows for the buildup of intrathoracic pressure. And then we don't get an effective cough or expulsion of secretions from the lower airway. So how do we determine if our neuromuscular patients are having lung dysfunction and therefore cough impairment and difficulty removing retained secretions from the airway? In our clinic, and what has become standard of care in ALS clinics, is spirometry testing, which includes the forced vital capacity and the FEV1 and the FEV1%. We also measure maximum inspiratory pressure, and unlike spirometry and the pulmonary function test, we don't have nomograms that have been validated for this measure. Normally, it's usually considered -90 to -120, with women being in the lower end of the normal range and men with the highest. Sometimes 108 centimeters of water pressure is used as a reference value in pulmonary function labs. Maximum inspiratory pressure is also sometimes used, but it's there are no validated nomograms for this measure. Effective cough is sometimes known to be between 45 and 60, or some labs use greater than 60 as a baseline normal value. In our clinic, we tend to use peak cough flow, and because it correlates positively with our forced vital capacity values, there's been some research on peak cough flows and their relationship to effective cough and airway clearance. John Bach and Chaudhry have done most of the research on this, and they have published research that shows that peak cough flows greater than 270 liters per minute are effective in maintaining airway clearance, and they suggest that we begin to monitor peak cough flows when the actual forced vital capacity drops to less than 2 liters. What is becoming more common in ALS and neuromuscular clinics is doing a end-tidal CO2 monitoring when patients come to clinic quarterly. We do need to measure their resting respiratory rate at the same time, though, because in many cases, as the lung volumes decrease due to diaphragm weakness, that we're seeing a higher respiratory rate to keep end-tidal CO2 values within normal limits. Oxygen levels do not decrease to below normal limits of, let's say, greater than 95% until a very end stage of this disease. But when you measure SpO2, it's very important to correlate that with the resting respiratory rate, because as the diaphragm weakens and resting lung volumes decrease, the patient may be having to increase their resting heart rate in order to maintain a normal SpO2. And of course, we must do our observation and our clinical assessment of the patients and not just rely on testing values. Are our patients using accessory muscles? Are they using the paradoxical abdominal movement? Are they actually, when they take a breath in, moving their abdominal muscles quickly inward to press up on the diaphragm to help them breathe? Are they using strong or weak abdominal movements when they're coughing? All of these things you can observe in your patients to add to your information. Auscultation, of course, one of our standbys. You want to listen, again, over the apical segments if you're worried that your patients are not mobilizing secretions. You may hear some wet or gurgling sounds from your patient as they're trying to cough or breathing. So you want to listen over the neck and tracheal area as well as the apical segments to see actually, are these airways actually in the lower airway, or are they sounds that are being transmitted from above the vocal cords to the lower airway? And again, palpation, if you can't really see what's going on with your patient, putting your hands over the lower abdomen and over the rib cage sometimes can give you a better idea of how the lungs are functioning. And also, since ALS usually starts out unilaterally and then progresses to bilaterally, you can visualize yourself whether the lungs are expanding equally on both sides, or if one side is expanding better than the other. So these are the airway clearance techniques that are most commonly used in the hospital today. Just physiotherapy, or some of us call it pulsar drainage and percussion. We have a whole range of exhaled positive pressure airway devices now. Intrapulmonary ventilation, high frequency chest wall compression, known as the vest or different varieties of the vest, and mechanical inexsufflation. The brand names are Cough Assist and Vital Cough. And then we have the lung hyperinflation therapy we call breath stacking, or active sigh breaths, or lung hyperexpansion, and then manually assisted coughing, which is sometimes referred to as quad coughing, or a seated Heimlich maneuver, in which you quickly compress the epigastric area while your patient coughs, or you can use your forearm to quickly compress the upper chest just below the clavicle. This can be targeted to family members in terms of training them prior to discharge. But all of these things are currently used to varying degrees of success in the hospital today. However, the use of airway clearance techniques are often not based on, let's say, strong science, but are based more on anecdotal evidence and historical practice, things that we've been doing for years. But unfortunately, there isn't a lot of high-level evidence to support any of the airway clearance techniques that we're currently doing today. Unfortunately, there's a lack of randomized controlled trials. The research is plagued by poor design, not enough study participants so that we can get good statistical information from them. Most of the studies are crossover studies that lack a control group or a non-treatment group. The endpoints or primary outcomes are often not ones that can be adequately validated because they're based on patient-reported sputum production or patient's tolerance of therapy. And in many cases, the researchers who are conducting the research and working with the patients are not blinded to, meaning that they are aware of the different treatment options, and so they may be inadvertently influencing the subject's preference of one treatment option over the other. And in the published research, at times the researchers do not account for or discuss their potential biases of one treatment over another. Well, fortunately for us, there are some systemic reviews or clinical analyses of airway clearance techniques. In the respiratory care in 2013, there was a task force that included Shauna Strickland and Dean Hess, among others, and they reviewed all the existing literature that had been published about airway clearance techniques, including in neuromuscular disease. And Dr. Strickland discussed and reviewed this at the AARC Congress last December. There's also a number of the Cochrane database reviews are also a very good place to go for a meta-analysis of the existing literature on effective airway clearance techniques. The AARC in their meta-analysis found that there was weak evidence that supported cough-assistant techniques be initiated when peak cough flows are reduced below 270 liters per minute. And in their review of the literature, the American Association of Neurology and their updated practice parameters in 2009 show that mechanical inexsufflation may be considered to clear secretions in people with ALS when they had reduced peak cough flows or an exacerbation of their disease. However, in all of the meta-analyses, there is a lack of sufficient evidence to recommend any of the current airway clearance techniques that we commonly do in the hospital. And this points to a need to design and implement properly designed studies to determine appropriate role of these therapies. And I'm hoping that that's something we can talk about at the end of this talk. But it's important to say that lack of evidence doesn't necessarily mean lack of benefit, and that we need to integrate quality research with the clinical practice and what we actually see in the hospital environment. But because of this, it is important to it's important to look at some basic considerations when we're thinking about recommending any type of airway clearance device. Of course, it needs to be individualized. There's different disease processes and their different stage of any of the neuromuscular diseases that your patients will come to the hospital with. So we need to understand our anatomy and physiology and our pathophysiology. And we need to look at the benefit of any treatment that we recommend. We need to be looking at, are there measurable ways that our treatments are improving our patient's symptoms? Is there any harm to the patient? And we certainly don't want to be implementing a therapy that may be causing any harm. And in these days of fiscal responsibility and reduced reimbursement for respiratory care in general, do the cost of any of our treatments justify the unproven outcomes? And what is the impact of treatments on staffing levels and equipment purchases. And also patient preference over one treatment or another, especially if we don't have objective outcomes to guide us. So these are all things to consider before recommending treatment of our patients, or if you are trying to talk to other respiratory care practitioners or pulmonologists or neurologists about what you think the most useful airway clearance technique might be for your patient. So again, I want to go back to what is normal airway anatomy and physiology and pathophysiology for our patients to help guide us in making these decisions. The small and large bronchioles expand in diameter and length when we first take a breath. And as we take a larger breath and expand to functional residual capacity, there's the diameter will enlarge. But then the change from FRC to total lung capacity is mostly in bronchial length. And of course, there is collateral alveolar ventilation. The gases want to follow the path of least resistance, so that when you first take a breath in, the air is going to flow into the alveoli that are already well inflated. So taking a larger breath, doing a breath hold, or a series of stacking breaths will allow air to flow from the well-inflated alveoli into the adjacent and underinflated ones. In neuromuscular diseases, the loss of resting lung volumes at night, especially if the patient is in a supine position, losing gravitational assist, and during the day, due to general lung muscle weakness, causes decrease in lung compliance. The benefit of lung volume replacement therapy, which there is some very good research to support, bilevel respiratory assisted devices, that's become a standard of care in ALS and other neuromuscular diseases. But this does not treat the absence of sigh breaths. So that's something to be considered even if we're doing lung volume replacement therapy at a normal resting lung volume of, say, 6 to 7 milliliters per kilogram of ideal body weight. So our patients, even with bilevel respiratory assisting devices, may continue to be at risk for atelectasis, especially if our patients are non-ambulatory and they spend most of their days in a wheelchair or sitting. There may be more compression on the lateral and basilar segments of the lungs. In the normal lungs, the alveolar pressure always provides the pressure head for a cough. That's that deep, deep breath in and then that breath hold. So that's where the flow of air and exhalation occurs. So that's something to keep in mind when we are recommending treatments for decreased cough or secretion retention. Elastic recoil also provides the transpulmonary pressure during active expiratory efforts with the cough and the ability to open and close the glottis effectively. We need to remember that neuromuscular diseases, they're not lung diseases per se, so that in the absence of comorbid lung disease like COPD or bronchiectasis, that the alveolar walls are normal, the lung parenchyma is normal, so that the most effective treatment may be those that augment and enhance normal lung function. We're replacing resting tidal volumes, we're providing adequate sigh breaths or lung hyperexpansion for alveolar recruitment to help us with an effective cough. And the lungs certainly don't exist in a vacuum, so we want to make sure that our patients are getting adequate hydration, that we're able to enhance nutrition for our patients, and many of them do become malnourished, and hard to keep the weight on, often because of the respiratory cost of breathing. And another reason to try to decrease the work of breathing is so that we don't expend a large number of our calories in just trying to breathe. We do encourage movement and exercise with our patients to the amount that they can, whether it's active or passive. And that's one of the best ways to help with secretion removal in the airways is movement. And so working closely with a member of your physical therapy team to design exercises for your neuromuscular patients will help a great deal in airway secretion management. Other considerations when choosing an in-hospital airway clearance technique is thinking about discharge, because the moment the patient is admitted to the hospital, we should be thinking about discharge. We certainly don't want to wait until the last hour, 24 hours before the patient goes home. So the therapies that will be best translated from hospital to home are those that can be performed independently by the patient themselves or with caregiver assistance. The portability of the equipment and techniques can also be very beneficial. And doing patient and family education while they're in the hospital, during each treatment and before discharge, having the patient and family do return demonstrations for you would be very helpful for them in continuing to manage their airway secretions or keeping their lungs healthy once they go home. Because many of our patients will be discharged home with treatments or techniques that and equipment, again, that will be coming from one of our D&D providers or home care providers. It's important that we try to communicate with our home care, respiratory care practitioners and have some coordination there. And, of course, our goal of therapy in all of these things is to try to keep our patients from being readmitted to the hospital. So because there is a lack of quality research and often a lack of agreement within our departments and within our facilities about the best ways to manage lower airway secretions in our neuromuscular patients, there are some techniques I'd like to share with you that have been very helpful in our ALS department, because we don't always agree either on what is the best way to manage our patients. One of the cases in our department was disagreements on how to best manage lung function testing in patients with bulbar disease. And so we actually instituted a gap analysis to try to come to some understanding or agreement on how to do that. So in the case here, we want a technique for identifying gaps in the medical evidence to guide airway management when quality research is not there to guide us. So one thing that's worked for us and perhaps would work for you is organizing a team or a committee that would be composed of respiratory care practitioners, pulmonologists, and maybe the neurologist in your facility. Setting aside specific meeting times, and we did it bi-monthly and didn't feel that that was too much of a burden, and to identify gaps that have led us to disagreements and how to manage airway secretions for our patients. We need to identify where we actually disagree. We want to formulate specific questions that we want to explore and try to keep it to 2 or 3. We want to work together and divide up the medical literature to explore and then find the best articles that we can and discuss those among ourselves. So to fill the gaps in our understanding or maybe in our clinical practice, we want to address the clinical questions that we have highlighted. And we want to propose research to answer the questions that are not answered through our medical literature research. Examples would be which assessments best determine respiratory insufficiency and airway compromise in our neuromuscular patients? What are the reliable outcomes of treatments? What can we measure in terms of objectively measuring treatments? And which supportive therapies, including non-respiratory ones, lead to successful outcomes? It may be that just supportive therapies in terms of hydration, nutrition, and movement, and antibiotics that are targeted to a specific pathogen might be the best way to go. At the end of this research and committee meetings, you might be able to design some new tools or specifically algorithms to help you in your assessment and treatment of your neuromuscular patients. Once you do this, then you can implement your, say, your test algorithm. And you can start testing and tracking your patient's response to treatment through this algorithm recommendations. And also track your staff adherence to the algorithm. Are people implementing it routinely or sporadically? You need to review your results on a regular basis. So you could implement it for 3 months and review, and then revise what you're doing based on that review and implement, and then review and revise again. So we have done this, and we have found it to be beneficial, as well as in find that we have more consistent care, and I think that's good for us as well as our patient. So the recommendations through this would be the gap analysis is useful when we don't have good evidence in respiratory care that might lead to inconsistent practice within our facility and perhaps tension and disagreement among the clinical staff. So the literature plus the consensus building plus monitoring of our own practice can lead us to more consistent recommendations for care, buy-in by all staff, and standardization of care within our center and adherence to agreed upon clinical practice. This process can lead us to new ideas for future research and improvement in patient care. So these are my take-home messages for you from what I and other respiratory care practitioners that work almost exclusively with neuromuscular patients are bringing to you, which are neuromuscular diseases impair cough due to a weakening diaphragm, weakening abdominal muscles, and in specific cases, the intercostal muscles and the bulbar muscles. In the absence of comorbid lung disease, the respiratory units, which are the alveolar, ducts and sacs, the bronchioles and capillaries, remain normal. So the most effective airway clearance therapy should be augment and support normal lung function. In the absence of functional cough response, non-respiratory supportive therapies may be sufficient. Consideration should be given to airway clearance therapies that can be used in the home following hospital discharge, and the cost of prescribing therapies include medical purchase, staff allocation, and third-party reimbursement. And this is the end of my presentation. But in closing, I'd like to add one more thing. I know that all of you are members of the AARC, and I invite you to join the Neurorespiratory Roundtable. That is where those of us who specialize in neuromuscular disease and neurorespiratory diseases communicate with one another, share best practice, ask questions, and our support from one another. We post articles there that we found to be particularly useful, and it's free. We also meet at all the AARC congresses, and so that we have a face-to-face and get to meet one another. And I'm happy to say that the AARC now is having more and more speakers and topics on neuromuscular diseases. So that is also a good way to get more information and also to share the information that you have and the best practice that you are forming in your clinics. So thank you very much for being here today and allowing me to speak on this topic.
Well, thank you so much, Lee. We have a whole slew of questions, and I'm going to try to get to as many of them as I can. Perhaps it's a good thing that you finished a few minutes early. Just to piggyback on what you said about the roundtable, I did post in the chat box a link to the Neurorespiratory Roundtable where you can join the discussion at no cost. Great way to share ideas, and I would highly recommend it. So I'm going to kind of work backwards a little bit here, Lee, on some of the questions we received. And there seems to be some good discussion about diaphragmatic pacing. One person had suggested if we start pacing early, would that create a bigger window for us to show benefit and improvement with the airway clearance techniques? And then somebody else chimed in that said, no, that may work at first, but it's going to lead to earlier fatigue of the diaphragm muscles. What's your take on diaphragmatic pacing?
Well, that is still being researched. Ray Anders is the surgeon that first researched this in neurorespiratory diseases and got FDA approval for the device. However, there were only 35 patients that were used to get that FDA approval. So what we're trying to research now, and includes my clinic, is which patients will best benefit from diaphragm pacing, specifically neurorespiratory patients like ALS patients. And there has to be some degree of motor neuron loss in order for it to be effective, but you also need to have a stimulatable diaphragm. So at this point, the inclusion criteria are that it has to have dropped to a certain degree, usually around 50% or a little less than 50% of predicted, but it can't have dropped so much that there's no longer a diaphragm to stimulate. The theory behind it is that by stimulating the diaphragm, that you help regrow the type 1 muscle fibers and the type 2 muscle fibers. So that is what's behind it. And it will not take the place of bilevel respiratory assistive devices, but it may be that people have more time off of them, or they may need lower replacement volumes or lower peak airway pressures in order to provide a normal resting tidal volume. So that's the thinking right now. But stay tuned, because there are 5 different sites that are participating in the research for diaphragm pacing in ALS specifically, and we'll have a better idea of how successful it's been and whether we should proceed to be placing it in even more patients.
Oh boy, I thought I was throwing you a 95-mile-an-hour heater there, and I think it ended up being a softball right over the heart of the plate for you. That was a great answer.
Thank you.
Another question that I'd be willing to bet a large number of our members with the AARC are impacted by, especially those that live in more or work in more rural areas. We had somebody make the comment that they were attempting to do some discharge planning for the home with a neuromuscular respiratory patient, and the only DME that they have to work with does not employ a respiratory therapist. And wondering if you might have any insight or recommendations on how to address that problem.
Oh, that's a tough one. And we actually have that same issue in California, because all of the major treatment centers are, of course, in the urban areas, and so many of our patients live in rural areas that are very sparsely populated, and the DME companies have to the RCPs or nursing staff have to drive quite some ways to get to them. Again, they may not employ a respiratory care practitioner. I don't have a really good answer for that. We're thinking about doing telemedicine. We're starting that in our clinic. That's really tough. I know this sounds like, maybe not very realistic, but Chuck Gutierrez, who was one of the first chairs of the Neurorespiratory Roundtable and works at the VA in Tampa, they started taking it on the road, and they have a van now where they can do lung function testing and treatment recommendations, that sort of thing, to rural areas. But it's just really sad when we don't have respiratory care practitioners who can help these patients. That's why I think sometimes if we can provide our patients in the hospital with very portable or non-equipment but very effective techniques for home, that can be very useful. And really good telephone follow-up, allocating the resources for that. So maybe between those two things, if any other people have some good answers out there, but it's very hard. It's very hard for us and very painful to know that our patients aren't going to be getting the best care through respiratory care practitioners.
We have
another long-winded answer. Sorry.
No, not at all. And it's a question with not an easy answer. And unfortunately, with the way reimbursement takes place right now in the home, it's likely only to get worse unless we get some legislation changes that allow respiratory therapists to be reimbursed in the home. But that's a different subject for a different day. We have lots and lots of questions about different types of therapy and different types of equipment. I'm going to get to that in just one second. Cal 4420 asks, is there any evidence that caffeine or other respiratory stimulants delay effect of or amelioration of symptoms, especially in the early stages of neuromuscular disease?
No, there aren't. As far as I know, I haven't read anything about that. So, no.
Fair enough. And my guess is that that perhaps you might spend a moment after this presentation researching that, and if we've got some information,
sure.
We can certainly
provide
that. Yeah, we can certainly provide that answer to the group. So we have lots and lots of questions about therapy and what is the best therapy, and does this therapy work or would it work for this group? Now, unfortunately, as you had said, there's not a lot of evidence. So with that said, I'm just going to rattle off some of the therapy that people have discussed. Maybe you can comment on it. And then as a secondary question, could you just tell us what you do? What's your approach? What's your preferred therapy, despite the fact that there's not a lot of strong evidence? Now, I thought that you made a good comment that just because there's not an evidence-based guideline or recommendation doesn't mean that the therapy isn't efficacious. People had talked about positive airway pressure therapy, EasyPAP, IPPB, the Aerobica device that's newly been out on the market for a year or so, the Flutter device, a rocking bed. Are any of these in your toolkit? Which ones do you use and which do you prefer?
Well, you're right that we don't have a lot of evidence to show that any of these are very successful. So I always say go back to what you know about basic anatomy and physiology and pathophysiology in these diseases, and have a real clear, objectively measured outcome and go with that. So that's, I mean, you want to determine one. I mean, I think when our patients come to the hospital, I mean, sadly they may come to us because they do have an exacerbation and they do have lower airway secretion retention. But just because you're hearing airway congestion in the apical segments, is that how much do we need to bring out the big guns? That's something that I'm starting to challenge a little bit more. If our patients come in and they can cough, I say try to see if we can just augment the coughing. If someone has a completely paralyzed diaphragm and abdominal muscles, then we need to do more to just assist with that. But how much do mechanical and electronic devices really help with this? So I think we need to see how effective our patient's breathing is when they come in, how effective their coughing is, and try to see if we can augment that before going to more experimental and untested ways of doing secretion mobilization devices. And we can't really translate what works with someone who has bronchiectasis or cystic fibrosis to neuromuscular disease, because neuromuscular diseases are not, again, lung diseases per se. The alveoli are fine, the lung parenchyma is fine. It's a pump issue, it's a diaphragm issue, or maybe a core muscle issue. So we need to think about that, and that needs to be what guides our decisions. So I really can't be in a position of saying X, Y, and Z works, because I'm going to the literature like everyone else, and I'm just not finding anything. And the AARC, in their meta-analysis, didn't find anything either. So, you know, we need more research.
Totally agree. Last question, you had talked about bringing out the quote-unquote big guns. Obviously, bilevel ventilation, NIV is the preferred ventilatory assist therapy, especially at night for these patients. But something, you know, in the last 6, 7, 8 years that's really had kind of a resurgence is the negative pressure ventilation with the biphasic cuirass. Do you have any experience using that, and what are your thoughts?
No, I don't have a lot of experience using that. I think that it certainly could play a role. It's more, as we know, more physiologic, and it may be something that that for the patients during the day, it would be very, very helpful. My understanding is that you do need to be in you know, in sort of a sitting up in a recumbent position. You have this hard shell on, and so during the day, people don't want to use positive pressure. They could use that, but at nighttime, my understanding, if someone is supine, it isn't going to work well. So it could be an adjunct to positive airway pressure. It's just not something that's used routinely in this. There may be patients with post-polio using it successfully, but there's not a lot of people in ALS using that. But here's the thing, if it works for patients and it works well and you're getting good lung volume replacement and you're able to measure that lung volume replacement, I think that might be some place where it's hard with our positive airway pressure devices. We are actually able to see exactly what lung volumes we are able to achieve, and we're able through the SD card and download data from all of our positive airway pressure devices, whether it's ventilators used non-invasively or your bilevel devices. We can see that with negative pressure ventilators, as far as I know, we can't really measure that, so we don't know how well we're treating our patients. But again, as a daytime adjunct, I don't see anything against it. But I'd like to say one thing, because I think you said, Doug, that was our last question. If any of you, and especially with the caffeine, and I'm a big fan of caffeine, but whether it really works in ALS or other neuromuscular diseases, and we know it has some benefits, I think, for people that have asthma, there is a great website called ALS Untangled, and there's a researcher who's affiliated with Duke University and the VA in Durham, North Carolina, that there are so many questions that are unanswered, and we don't want to ignore or reject anything out of hand. When when there may not be good research to guide us. So what he and other people around the world are doing is when anyone poses a question about potential treatments, and I'm talking about it could be a homeopathic treatment or Ayurvedic medicine or anything, high doses of a particular vitamin or mineral, that he gets his team on it. And so we don't reject anything out of hand, but there needs to be a way to research different treatment options. So I would recommend, again, ALS Untangled as a really good site to go to not only try to find answers to some of the questions posed here, especially around non-equipment options, but also maybe to pose some questions to the researchers at ALS Untangled, or maybe even become a researcher and participate in researching and increasing our knowledge base for treatment in ALS.
Lee, I think that is the absolute perfect way to close out our presentation today. You know, we had 2 or 3 people right at the very end come in, and I think they summarized it nicely as well as you did. But really, when we look at treatment options, especially with lack of evidence, it really comes down to making treatment decisions that are specific to the patient that you're working with. And if it works for them, then stick with it and keep going. So, but Lee, thank you so very much for joining us today. We really, really appreciate it. We had 375 people on board today. Probably another 100 or 200 that were part of a larger group. And just think, if we had all of those people join the specialty sector or join the roundtable, it could be potentially become a specialty section. So we would certainly recommend for you to do that as well. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation. Lee, thank you so very much. Hey, you have a wonderful day.
Thank you, everybody.